Hi, and welcome to your Level 2 Adult Resuscitation training. Please sit back, relax, and watch this entire video. The learning outcomes for the training are for you to have an understanding of the standardised approach to adult resuscitation, including a summary of the RESPECT process within LGHT, the core practical skills associated with CPR, which are the assessment of the collapsed person, confirmation of cardiac arrest and making a 2222 call, effective high-quality chest compressions, safe use of a defibrillator, and how to insert an eye gel. We will also look at PPE requirements during CPR, moving on to ligature emergencies and maternal CPR, and we will give you an overview of adult choking and anaphylaxis. RESPECT is the recommended summary plan for emergency care and treatment, and it brings together the individual's expertise about themselves and what is important to them, but also together with our knowledge or the clinician's knowledge about what is known about the benefits and risks of any available treatment options. Every acute admission to our trust should have a RESPECT form in place. It is purely digital, so on PPM Plus you can add a clinical document and we can add the RESPECT in for a patient. An alert will then show that the patient has a RESPECT plan in place, plus or minus a DNA CPR. If they are not for a cardiopulmonary resuscitation attempt, so DNA CPR, there will be a red alert on PPM Plus. If it just says RESPECT, then the patient is for CPR, and we look into their RESPECT form to see what their full escalation plan is. Please ensure that you only print out the RESPECT form when the patient is being discharged from our care. We hand the patient the RESPECT form then. Otherwise, we keep it digitally on our system. Should the patient be transferred somewhere with paramedics, we can then print the form out because the paramedics don't have access to our system. It's really important that we do give this piece of paper and this information to patients on discharge. We don't want them to be shocked at the fact that they've got a RESPECT form in place when they leave and look at their documents at home. Please ensure your discharging doctors are actually talking to your patients and that they update anything on the RESPECT form prior to the patient's discharge. Should a duplicate RESPECT form alert show on PPM Plus, please alert the home team for that patient. This means that the merging of digital records has occurred and this patient for some reason has two RESPECT forms. Please allow the doctors to review the RESPECT forms and edit them and save the most relevant one. Once you've done that, then the duplicate RESPECT form alert will then disappear. Communications with this is really key to this process. It must be communicated during handovers, any transfers, safety huddles, MDT meetings, and of course on discharge. Again, only print out if we're discharging or transferring our patient. If you are at all in doubt of the CPR status of your patient, start CPR. Then you can log on, or somebody can log on to PPM Plus and clarify the CPR status. However, do keep going until the crash team are there and they can make an informed decision to if we continue CPR or not. Even if a patient has a DNA CPR in place, it may not apply in all situations, such as a reversible cause like choking or anything unrelated to a progressive illness. Moving on to the core practical skills involved in CPR, we will look at how to assess a collapsed person and perform high-quality chest compressions. The majority of our patients do show clinical signs of deterioration prior to cardiac arrest. However, we cannot always prevent cardiac arrest. Therefore, we really need to know how to recognise and diagnose it, allowing the early activation of a 2222 call. High quality chest compressions must be commenced.
Assessment in CPR. The following videos will demonstrate how to assess a collapsed patient, summon help and commence chest compressions. Always check for personal safety when approaching the collapsed patient. Assess the patient for a response using a shout and shake. If no response, shout for help or pull the emergency buzzer.
Could I get some help here, please? Hi Carl, how can I help? Just bear with me.
Open the patient's airway using a head tilt chin lift and assess for breathing or signs of life for no longer than 10 seconds.
Okay, there's no signs of life. Could you put a 2222 call out when the crash trolley over, please?
Will do.
If there is no breathing or signs of life, ask for a 2222 adult cardiac arrest call to be placed and commence chest compressions. If no help is available, please leave the patient and call 2222 before returning to the patient and commencing chest compressions. To do chest compressions, place your hands in the center of the patient's chest. Keep arms locked and straight. Ensure your shoulders are over the heels of your hands. And compress the chest to a depth of 5 to 6 centimeters, ensuring full recoil between compressions at a rate of 100 to 120 compressions per minute. If you're unsure of the rate, feel free to sing "Staying Alive" by the Bee Gees, which will give you a compression rate of 106 compressions per minute. Once compressions have started, it is essential they are continued without stopping to give breaths until further equipment is available. To activate the crash team, locate your nearest phone and dial 2222. State adult cardiac arrest call and give your location, floor and wing. For example, adult cardiac arrest call L20 F floor Jubilee wing.
Adult cardiac arrest L20 F floor Jubilee wing.
If you're asked to get the crash trolley, please locate your nearest trolley. Unplug the defibrillator, storing the wires away to prevent a trip hazard, and then push the trolley safely to the location of the cardiac arrest. On arrival of the crash trolley, it is essential that chest compressions are continued without interruption, whilst pads are applied to the patient's bare chest in preparation for the first rhythm check and potential defibrillation.
Along with high-quality chest compressions, the use of an automated external defibrillator or an AED is proven to increase survival chances for patients in a shockable rhythm. This is why we put a lot of emphasis on doing high-quality chest compressions followed by the use of a defib. This entails good pad placement and early defibrillation. So if we can defibrillate a patient within 3 to 5 minutes of the onset of cardiac arrest, it can increase their survival for this group of patients to as high as 70%.
How to use an automated external defibrillator. The following video will demonstrate how to apply multifunction pads, switch on and use a defibrillator in automated mode. The R-Series Plus is a fully functional manual defibrillator that powers on as an AED. It can be converted to a manual defibrillator with the push of 2 buttons. The following video will demonstrate how to use this device in AED mode only. For instruction on manual defibrillation, please contact resuscitation services to arrange this. One-step pads should remain connected to the defibrillator at all times. To connect the pads to the one-step cable, slide the end of the cable into the electrode connector. These should slide together easily and create a tight connection. To open the pads, grasp the packaging at the yellow triangle and firmly pull open, separating the 2 sides. Pull the cable up from the package to separate it. To apply the pads, grasp the rectangular pad labelled 1 and peel it from the plastic liner by lifting at the red tab at the base. Roll the pad onto the patient's bare chest below the right clavicle. Remove the triangular pad labelled 2 and peel it from the plastic liner by lifting at the red tab at the base. Roll this pad into the left mid-axillary line. It should be noted that chest compressions are continued during application. Before using, verify that the defibrillator is ready for use by noting the green check mark on the front panel. If a red X is seen, one person should continue CPR, whilst another goes to get the nearest defibrillator with a green check mark. To begin, simply turn the defibrillator on. You will notice that the defibrillator displays AED. The defibrillator will function as an AED, providing prompts and instructions such as "stand clear" in readiness for rhythm analysis. Follow the prompts provided with the audible and visual alerts.
Stand clear, please, Carl. Oxygen's away. Everybody's clear. It's analysing.
The defibrillator will now analyse the patient's rhythm.
No shock advised. Check pulse.
Please check pulse, Carl.
If a non-shockable rhythm is detected, the device will advise a pulse check.
No pulse.
Commence CPR, please.
If no pulse, perform CPR.
If no sign of life is detected, CPR should be recommenced immediately. If a shockable rhythm is detected, the device will charge itself and instruct you to press shock. Before shocking the patient, ensure the environment is safe for defibrillation to occur. Remove high concentration oxygen, if present, from the patient. Confirm that no one is touching the patient. Look to make sure all persons are clear of the patient, the bed, and any equipment connected to the patient. Loudly warn all persons to stand clear. The default defibrillation energy protocol of the defibrillator is 120, 150, 200 joules for adult patients.
Stand clear.
Stand clear, please. Oxygen's away. There's clear.
Press the illuminated shock button.
Shocking now.
Shock.
Resume
Perform
CPR.
CPR.
Immediately following defibrillation, recommence CPR promptly for 2 minutes. CPR should only be stopped during this period if the patient shows a sign of life. The defibrillator will prompt a pause in CPR to analyse the rhythm every 2 minutes. Once compressions have been recommenced, please secure the airway and commence ventilations.
Once you have started high-quality chest compressions and you've used the defibrillator with your patient, when staff become available, it's really essential that we start to manage that patient's airway and oxygenate them. And this can easily be achieved by the use of a supraglottic airway device such as the iGel.
How to use an iGel and commence ventilations. The iGel is a supraglottic airway device made of a medical-grade thermoplastic elastomer, which is soft, gel-like, and easy and rapid to insert. When correctly seated, it creates a non-inflatable anatomical seal of the pharyngeal, laryngeal, and perilaryngeal structures. The following video will demonstrate how to correctly prepare and insert an iGel and commence ventilations using a bag valve mask device. Prior to insertion, visually inspect the patient's mouth for any obvious obstructions and apply suction where necessary. Always ensure that dentures or plates are removed from the mouth before attempting insertion. Ensure the oxygen cylinder valve is open using the key provided. Connect the bag valve mask device to the oxygen flow regulator and set to 15 litres. To turn on suction, rotate the brass fitting in the direction of the arrow. Please ensure suction is turned off when not required. To insert the iGel, open the packet and remove the device. Place a small bolus of lubricant onto the middle of the smooth surface of the protective cradle in preparation for lubrication. Grasp the device along the integral bite block and lubricate the back, sides and front of the cuff with a thin layer of lubricant. Inspect the device carefully, confirming there are no foreign bodies or a bolus of lubricant obstructing the distal opening. To insert the device, grasp the lubricated device firmly along the integral bite block and position the device so that the cuff outlet is facing toward the chin of the patient. The patient should be in the sniffing the morning air position, with the head extended and the neck flexed. Gently press down on the patient's chin and introduce the leading soft tip into the mouth in a direction towards the hard palate. Glide the device downwards and backwards along the hard palate with a continuous but gentle push until definitive resistance is felt. Once in position, the tip of the device should be located into the upper esophageal opening and the cuff should be located against the laryngeal framework. The incisors should be resting on the integral bite block. Once definitive resistance is met and the teeth are located on the integral bite block, do not repeatedly push the device down or apply excessive force during insertion. The device should now be secured using the strap provided. It should be noted that chest compressions are continued during insertion. A ratio of 30 compressions to 2 ventilations should now be maintained.
CPR and PPE guidance within the Trust. When performing CPR on a patient, please remember to protect yourselves. Standard PPE for CPR is a minimum of gloves and an apron. For patients who have an airborne infection risk such as flu A surgical face mask must also be worn with the gloves and apron. For patients who have TB or measles, for example, please don an FFP3 fit-tested face mask, gown and gloves. Should you wish to wear full PPE for any CPR attempt to protect yourselves, please do so and you'll be supported with this. Make sure your area has easy access to PPE to help protect us all. And please refer to our intranet page for future updates regarding CPR and PPE.
We'll just move on to maternal CPR and some potential modifications that you may need to perform. Should you find a collapsed pregnant patient, please assess using the ABC head tilt chin lift approach and confirm cardiac arrest. Ensure that a 2222 call has been placed, asking for the adult, obstetric and neonatal teams to be called. Keep the patient flat, back on a hard surface, and perform chest compressions in the usual way for an adult patient. Once more help does arrive, if the patient's uterus is palpable, and this is usually from around 20 weeks gestation, then left uterine displacement should be performed, either with one hand or two hand technique as shown in these pictures. This really helps to move the uterus and the fetus off the inferior vena cava and aorta, and this increases the blood flow back to the heart and actually increases the effectiveness of the chest compressions that you're performing.
Ligature emergency. A ligature can be made of anything, such as clothing, bed sheets, wires, just to name a few. A ligature emergency is when we find somebody with a ligature around their neck. They can be suspended, so hanging, or tied to a fixed point and leaning their body weight forward. In a ligature emergency, ensure your own safety at all times, call for help, or you can use your emergency buzzer. If the person is unconscious, place a 2222 adult cardiac arrest call stating the location of the emergency. You will also need to call security on 49999 stating ligature emergency and your location. Our security team are trained in such emergencies and carry the appropriate equipment. If the person is suspended, do not delay cutting them down. If you deem yourself able, you can take their body weight as the suspended part of the ligature is cut and support the person to the ground. If you are unable to take their weight, please just cut them down. Once cut down, assess for signs of life. However, do not perform a head tilt chin lift as there could be damage to their neck. If electrical wiring has been used as a ligature, make sure it is unplugged prior to cutting. This will prevent you from getting an electric shock. If the person is conscious, please call security on 49999 stating ligature emergency along with your location. While waiting for security to arrive, you can try to de-escalate the situation, talking to the person, see if they will remove the ligature themselves. Do not attempt to remove their ligature. Your safety is paramount.
Ligature emergency rescue equipment. The hook knife. This is only to be used by trained personnel. If your area has been risk assessed as requiring a hook knife, you will receive training. Do not use this piece of equipment if you have not received training from LTHT. The hook knife is kept in the top drawer of the crash trolley, and this is in the risk assessed areas only. Our security team will carry their own hook knives and must be called to any ligature emergency. The tough cut scissors are kept in the top drawer of the crash trolley. These are for ligature rescue only. If used for ligature rescue, they must be replaced.
Now we're going to look at choking. So choking can be a partial or a complete airway obstruction. You need to assess the person. If they can cough, encourage them to do so, as this means they can get air in and out past that partial obstruction. You can call for help if required. If the person is conscious yet unable to cough or has an ineffective cough, this could be a complete airway obstruction. Do call for help, and this can include a 2222 adult cardiac arrest call. Give the person up to 5 back blows as shown in the picture here. If the obstruction is moved at this point, that's really good. We can just monitor the person and see how they do. If the obstruction remains after the 5 back blows, you can then move on to the up to 5 abdominal thrusts as shown in the other picture. Please ensure you have placed a call for extra help. If the obstruction is not cleared and the person remains conscious, please go back to up to 5 back blows followed by up to 5 abdominal thrusts until the obstruction is dislodged. A conscious choking person can quickly become an unconscious choking person. If this happens, ensure that they are laid flat on their back, ensure a 2222 call has been placed, and perform 30 chest compressions. The chest compressions are not because we think their heart has stopped at this point. It's to use their chest and their lungs like a big pair of bellows and try and force the obstruction out. If the obstruction hasn't cleared after the 30 initial chest compressions, please perform a further 30 chest compressions. If the obstruction remains, you can now be in a full cardiac arrest. You need to continue to do chest compressions and use a defibrillator. Please do not attempt to manage their airway. Simply perform continuous chest compressions and inform the crash team that the patient has choked. The recovery position. After some events, such as choking, a person can remain unconscious and may require a change to their position to help prevent obstructions, such as vomit, entering their airway. To achieve the recovery position, place the arm that is closest to you in the bent position, roughly right angles at the elbow and shoulder. Place their other arm across their chest with their hand resting against their face. Bend their leg, which is furthest from you, so it is propped at an angle. Hold their thigh and roll them towards you. Once in the correct position, tilt their head back to open their airway and continue to monitor them. Anaphylaxis is a severe, life-threatening medical emergency. It's the body's overwhelming reaction to an allergen such as food or medication. If you suspect anaphylaxis, we need to act quickly. If you have given your patient a drug or they've been exposed to an allergen and they become unwell very quickly, this may be anaphylaxis. If their airway is starting to become noisy, such as with a stridor, or starting to swell, once an airway swells, it can only swell one way, which is inwards. Therefore, they are cutting off the air supply to the lungs. If their respiratory rate or effort increases, they may also drop their saturations, and their heart rate may increase and their blood pressure drop. All this can show you signs of anaphylactic shock. Get local help if available, get doctors. If no help is available, please call 2222 and place an adult cardiac arrest call. Get your patient into a semi-recumbent position, elevating their legs if possible. They may need 15 litres of oxygen. They would definitely need IM adrenaline 1 in 1,000. This will be found in the blue drug box on your crash trolley. If you are waiting for the doctors or a prescriber to arrive, if you deem yourself competent to give IM injections, you can give IM adrenaline 1 in 1,000 in an anaphylactic emergency prior to prescription being written. Please give half a ml or 500 micrograms of adrenaline 1 in 1,000 from the glass ampule in your crash trolley and give it into a large muscle. Monitor your patient carefully. If within 5 minutes things deteriorate and they get worse, you can give a second dose of IM adrenaline 1 in 1,000, and that's a further half a ml or 500 micrograms prior to prescription. Continue to monitor them and inform the team of what has happened when they arrive. Before the team or the doctors leave your area, please ensure they prescribe any drug that has been given in that situation, such as oxygen and adrenaline.
Once you've watched the video, please attend a chest compression assessment session. If you work on a periphery site or at the LGI, please try contacting your clinical educator who may have the equipment for you to complete your assessment within your own CSU. If your clinical educator doesn't offer this, or you're based at Jimmy's, please just pop in to see us at the Resuscitation Education Centre, which is 3rd floor of Chancellor's Wing. We're open Monday to Friday, 8:30 till 3:30 for you to complete your assessment. You will be required to sign a register which forms your self-declaration stating you have watched and understood this video. The assessment is then self-directed using a SIM pad and a mannequin. Full instructions are provided with our equipment. Please ensure that you do read the instructions and have a practice at the compression-only CPR and then attempt your 1-minute compression-only assessment. Please save the assessment by typing your name in to the SIM pad and then your result will be shown. Fingers crossed you've got above 80% and then you are free to leave. Please clean all the equipment after use. If you haven't achieved 80%, do come and find one of the resuscitation officers and we'll be able to support you further. It can take up to 14 days for your training interface to update to say you've completed your training.
You'll be pleased to know we are now at the end of this part of your training. We have given you a standardised approach to adult resuscitation. This included a summary of the RESPECT process with an LTHT, the core practical skills. You have watched the videos associated with the assessment of the collapsed person, confirmation of cardiac arrest and placing a 2222 adult cardiac arrest call, effective high quality chest compressions, the safe use of a defibrillator and how to insert an eye gel. PPE requirements within CPR, ligature emergencies and maternal CPR have also been covered. We gave you an overview of adult choking and anaphylaxis. To complete your training, you will need to attend a drop-in session for your chest compression assessment, either with your clinical educator or you can visit us at the Resuscitation Education Centre, 3rd floor of Chancellor's Wing. We are open Monday to Friday, excluding bank holidays, between 8:30 and 3:15. Once both elements of your training have been completed, it will be updated for 12 months. Thank you for your time today.